There's nothing simple about the human foot. It's one of the most incredible and complex bioengineered parts of our anatomy. It combines power and speed with delicate movement and balance, solid stability with acute sensitivity, and endurance to take us almost anywhere we want to go for more than 100 years. It's kind of a cool statement. So here's Walther's foot and ankle stability pamphlet. And this actually inside shows some of the muscles that we've been talking about this weekend. And I've used this pamphlet in the past to show patients where to rub their origins and insertions of the posterior tibialis or anterior tibialis or things like that. And then there's a foot pronation pamphlet as well. So let's talk about foot pronation and support. There's a sign called Helbing's sign. And I thought I had a slide of it, but I guess I don't. Helbing's sign is sighting down, the patient standing, sighting down the Achilles tendon, the back of the calf down the Achilles tendon. And so what you're doing is the patient's standing and you're looking at the Achilles tendon coming down, and it should come straight down from the gastrocsoleus into the Achilles, into the calcaneus. What you'll see in the Helbing sign in pronation, the foot pronates, and the Helbing sign is the Achilles tendon has a bend in it. Has a bend related to the pronation. It's like a bend in it. Actually a bend, I think, like that. I'm doing it backwards. And you can see that. And Dr. Sheffield didn't have that, but I was actually looking at that. And had she had it, I'd point it out to you. And in a minute, we're going to kind of look at each other's ankles and Achilles tendons for a Helbing sign. And then what you'll see in foot pronation is a weak posterior tibialis or a weak anterior tibialis, like we talked about. And then shock absorber will be positive, and typically you'd see a lateral talus, that's the most common thing, or a drop navicular, or drop first or second cuneiform as part of the foot pronation. There's a figure of 8 taping which can be done, which is popular and is reported in the back of a lot of chiropractic magazines, and that helps to support the arch. And you can check the patient's shoes, and the shoe wear is something which actually can be as a cause of foot pronation, but then it can also affect and perpetuate foot pronation. So the foot pronation, there's a tendency for shoe wear to be on the lateral heel of the worn shoe. So what happens is we normally, our heel strikes first and our foot is in supination. Then the weight transfers to the little toe and then across the metatarsal arch, and then we spring off the big toe. And what happens when there's a tendency for pronation, the heel strikes, the foot strikes laterally and then rolls across medially, and the arch pronates at that point. So to compensate for that, what happens is people instinctively supinate too far, so they hit and drag their lateral heel much more than they should, because they know they're going to roll into pronation, so they actually start out farther. They drag their heel, they're more on their lateral foot, then they roll farther, and there's a lot more movement then in the foot into pronation, but as a result of that, there's wear on the lateral heel and a compensatory activity for that foot pronation. And you see the lateral heel, the shoe worn down, and that is a good clue that there's pronation on that particular side of the foot. Sometimes you see it bilaterally. So there's some reports about orthotics, and personally, for most people, I'm not a big fan of orthotics, especially hard orthotics. Hard orthotics are like crutches. Soft orthotics, which allow some play in the foot, allow what are called positive supporting reflexes of the foot to fire. And every time we put weight on our foot, the foot spreads out, and the ligaments and the muscles in the bottom of the foot, as the foot spreads out with weight, fire messages which turn on what's called the positive supporting effect reflexes, which turn on all of our extensor muscles and hold us upright. And so if you put a support underneath there so that the foot muscles don't stretch and the foot ligaments don't stretch at all, then you lose the positive supporting effect. And you'll see, as we talk about some of the importance of the proprioception from the foot a little later on, how important that is in maintaining our posture and our structural stability, and how taking that away can create so many more injuries in our body. So that said, still, with people who have problems with pronation and they use orthotics, what they found was in studies that walking heart rate would decrease by 6% with orthotics in patients who had foot pronation. Walking systolic blood pressure would decrease by 4%. Walking oxygen consumption would decrease by 8% because the patient didn't have to work so hard. Because imagine when the foot pronation is taking place, there's a lot more movement in the foot, as we just talked about. There's also a lot more movement in the rest of the muscles. There's more muscular activity to maintain normal gait because you're not walking in an efficient way. And so there's the decrease in oxygen consumption with orthotics, and an increase in energy efficiency by 8%, and a decrease in energy loss by 8%, which is that walking O2 consumption 8% decrease. So there is some value to supporting the arches, especially in patients who have very badly orthopedically broken down arches, or sometimes in people who have pes cavus, very, very high arches. And sometimes the very, very high arches, they were just born in a way that's not compatible with gravity, and they need to have some kind of support for that as well. So the normal weight-bearing contacts are on the heel and the lateral fifth toe and over the sesamoid bones on the first toe. And so we do a postural analysis of the foot. We look to see if there's an arch. And then we do a postural analysis. Here we see that if we look, you can sort of see that the right foot is pronated here, and the left arch is present. It's kind of hard to see, but that's what that shows there. And here you see a supinated posture of the right foot. There's a higher arch there. You can look at the posture of the foot, and then you can also palpate under the arch, which I did earlier as well, to see if one side is tender compared to the other, or if both are tender. And typically, if you palpate into the arch, even if there's an arch there, if there's a tendency for pronation, it'll be very tender. And in a foot pronation patient, that's one of the indications they need to do something to support that medial longitudinal arch, which is first line of defense is going to be treat the posterior tibialis and or anterior tibialis, and then correct any foot subluxations where the medial longitudinal arch has subluxations that have dropped, correct the talus or even the calcaneus in the foot to make the mechanics of the foot more appropriate. So if you have pain in the medial longitudinal arch on palpation and you laterally rotate the tibia and you palpate the arch, while you do that, the pain will decrease in a foot pronation. Does anybody here have bad foot pronation? Okay, David, come on up for me, please.
Well, if someone has an anatomically short leg and they put a lift in the shoe to compensate, can that have adverse effects on the dynamics of the foot?
A person has an anatomical short leg and they put a lift in the shoe to compensate. Can that have adverse effects? Well, most of the time it's going to have good effects, except if you have an anatomically short leg, do you want to lift just the heel, which some people do? You want to lift the whole foot. Because if you lift the heel only, you're changing the way the foot hits. So you'd want to lift the whole foot. And then there's all kinds of ways of trying to measure which is how much lift to use and so on. One of the things we can do in AK is we can actually test people in a gait pattern. We can test them statically and put a foot lift in and see if it strengthens or weakens. Usually do this after a week, after you treat the patient, and put a lift in. And when you get the appropriate lift in and the person stands on it for 30 seconds, there'll be no weakening. But whatever you were fixing before that's winding down because of the short leg will not weaken and stay put when you get the exact right lift within a millimeter or two. If you put the wrong lift in or no lift in, whatever you fix will wind down. But it takes 30 to 45 seconds for it to show up. What we found out works a lot better is you put the person in the gait pattern with both feet flat on the floor but still in a weight-bearing gait pattern, and put the lift in then and see if the muscles fire on and off like they should. And if they fire and you get the right lift in, the muscles will fire in normal gait pattern as they should, right and left. Test the lat maybe in the pec, for example. And you can test the lift height that way to make sure you've got the right one. There are all kinds of formulas and different disagreements. This should be a half the anatomical leg length difference or the whole or whatever. You can muscle test them and find out, but always do it at the end of a treatment. So stand up for me, please. And please face that way. And here you see a little bit like a Helbing sign. If you can see that, I don't know. But instead of, this one comes pretty much straight down, and this one, it comes in and out a little bit. Can you see that right there? A little bit of Helbing sign, okay? Now turn around and face the other way, please. You can palpate for the arch. Is it tender there? Tender there? Okay, so this is the side the Helbing sign was on, so it's a little mild. Now, all you do, I don't want you to think about lifting your arch. I just want you to rotate your tibia that way. And when you rotate the tibia laterally, it automatically raises the arch. Is it tender there? Less tender. So that's good, thank you very much. I might call you back for a minute. So there's a Helbing sign, and there's a test to see about foot pronation and see that when you rotate the tibia, it takes the pronation out. Now that also tells you that when you have pronation, the tibia is going to rotate in, and it's going to create all kind of postural adaptations all the way up the entire structural body and also the entire neuraxis. Another thing you can do is you can draw a line down the tibia. When you draw a line straight down the tibia, it should end up at the second toe, like that. That's normal. There's another postural evaluation of the foot and ankle. You can do it in reality like we've done here. You can just eyeball it or take a string and draw it down. What you'll see is, in some patients, you draw the line down the foot and it goes to like the fourth toe or something here. Or draw a line down the foot and it goes to the first toe. This gives you a clue of some of the foot muscle imbalances to look for. It's a postural analysis of the foot with the patient supine. So shock absorber technique simulates weight bearing, and the shock shock the joint in many potential vectors. It corrects muscles, it corrects subluxations, can be used in any joint. So we do the shock absorber technique as we've done and shown previously. When it's positive, we could also do it on other shock absorbers like the knee or the elbow or the wrist. And we'll actually talk about these in future sessions. So the AK rule of extremity challenging is always adjust in the direction of strengthening and adjust in the direction opposite from that which causes inhibition. So muscles, there are some particular muscles that are related to specific foot subluxations. Way back when, Dr. Goodhart observed that the psoas muscle was related to a lateral talus, that when there's a lateral talus subluxation, which will create a pronation problem or be part of a pronation problem, that lateral talus was related to a weak psoas on the same side. If he found a weak psoas recurred, he'd look at the lateral talus. It was another doctor who found out that the lateral cuboid was related to a weak tensor fascia lata. And then another doctor, one of them was a Dr. Doss in Alabama, discovered that the drop navicular, drop medial longitudinal arch would be related to weak adductors. So if you get recurrence of these muscle weaknesses, it would guide you to look at those particular foot subluxations. Psoas, talus, TFL cuboid, adductors, navicular, or I would say navicular in first cuneiform also. And so this is helpful sometimes when you're treating a patient and you see these weak muscles to put in your head to better check those subluxations of those particular feet bones. So the pain point for the lateral talus is right under the lateral malleolus right here. It's lateral, it's sort of pushing out there. It hurts when you palpate there. And you can adjust the talus as you've seen me do by tractioning and adjusting straight medially, or finding the vector from anterior to posterior, posterior to anterior that helps to make that correction.